Good afternoon and welcome to the Tourette Association of America's 2021 Virtual Conference. I'm Angela Sullivan, Medical Project Manager at the TAA, and I will be the moderator for this session. Thank you for joining us for the present and future of therapeutics in TS. I'd like to take a moment to thank our platinum sponsors, the Warner Fund and Pharma, as well as our donors and supporters for making this free conference possible. To support educational programming like this, you may visit tourette.org/donate to contribute today. During the session, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments in the questions panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. It is my pleasure to introduce you to our presenters, Drs. Irene Malaty, Juhi Jimenez-Shahed, and Rebecca Lehman. Dr. Malaty is an associate professor in the Department of Neurology at the Fiksel Institute for Neurological Diseases at the University of Florida Movement Disorders. Dr. Rebecca Lehman is an associate professor of clinical pediatrics at Prisma Health Midlands, University of South Carolina, and Columbia, South Carolina. And Dr. Juhi Jimenez-Shahed is an associate professor of neurology and neurosurgery at the Icahn School of Medicine at Mount Sinai. They are all active members of the TAA's Medical Advisory Board. To learn more about each of our presenters, you can visit tourette.org, and I believe they both will do a very brief introduction as well to share more. Thank you all so much for being here, and you may go ahead with your presentation.
Okay, hello, I'm Irene Malaty, like you heard, from the University of Florida. Okay. And we'll be talking about the present and future therapeutics for Tourette syndrome. So I'm going to talk to you about established treatments that are already on the market. Juhi will share with you about deep brain stimulation and cannabinoids or cannabis-based treatments. And Becky will talk about investigational or coming research that's going on for new things in the future. So that will kind of round out our presentation. So I participate in research with a lot of different entities. None of them affect the content of this presentation, but I will be presenting things that are off-label, meaning things that we use to treat Tourette that are not necessarily specifically FDA approved for tics or Tourette syndrome. Okay, so in this section, we're going to talk about general considerations in choosing whether to start medication for tics. We're going to talk about the current options that are available. And we're going to discuss that the American Academy of Neurology has produced guidelines that help approach what we call evidence-based treatment considerations. That means, how do we decide what to use based on research that's been done and what we know and what's been proven? So this is a picture of the natural history of Tourette syndrome. It means that oftentimes, something just changed with the presentation. It means, thank you, that oftentimes attention deficit disorder or attention difficulties might present even before tics, as early as 3.5 years old in some patients. Later on, motor tics tend to show up before vocal tics, but that's not true for every person. And later on, it's more common to see symptoms of obsessive compulsive behaviors. It's common that tics may present in the 5 to 8-year-old range. They might increase in the 10 to 14-year-old range, and they might get better or even go away in late adolescence or adulthood. And I'm sure there are hundreds of people on this call who might tell us, well, that's not exactly how it went in my case. And we know that there are many, many individual variables that are different person to person. But as a rule, sometimes tics may get better and sometimes tics may go away. So some might ask, well, should you treat them? Should you not treat them? Should you wait and see if they can just go away? And this is kind of an important question to think about. So there are some general rules or guidelines of how to approach, should I treat my tics or should my loved one treat his or her tics? And the first thing is, who is the person living with the tics? So a lot of times as parents, we really want what's best for our children. We worry about how our children will experience the world around them. But sometimes our kids could be just fine with tics that they're experiencing and may not be actually negatively affected in the way that we might be concerned. So it's important to ask the person living with the tics, do these bother you? And of course, there are situations where a parent might recognize a disruption by tics that the individual is less in touch with. And so we have to look at it as a unit and as a family and discuss together. Are the tics causing social disruption? Is there any social isolation or bullying taking place? Are the tics interfering with schoolwork? Sometimes tics could be distracting. Sometimes trying not to have tics can be distracting. So holding them in can sometimes be a distraction from concentration. Sometimes tics of blinking or looking off to the side could distract us if we're trying to read. And some tics can be painful or self-injurious. So there may be tics like strong head jerking that can cause pain in the neck or can have other risks associated with it. Sometimes tics may involve hitting oneself or doing things that could be painful, and that might be a reason to address them. How severe are the tics? Do they have an impact on self-esteem? So it's not just an are there tics question, it's a question of how much are the tics affecting the wellness and the happiness and the success of the individual. In adults, the same questions come up in a slightly different way. So are they interfering with work success? Are they interfering with relationships? Or do they bother the person? And it's not always that severe tics are always bothersome and mild tics are never bothersome. Sometimes mild tics are super bothersome to a person, and sometimes really severe tics are well tolerated by a person. So we have to decide if it's important to treat them. So these are the big three to think about, the big three priorities. One is prioritize what symptoms are the most disruptive. Many people with tics, in fact, the majority, don't only experience tics. They may experience anxiety, they may experience obsessive thoughts, they may experience attention difficulties, and sometimes those issues are the most important thing that's affecting quality of life and happiness, and we need to start addressing those before we worry about the tics. So we always want to start with what's causing the most difficulty. Next, we want to have realistic expectations. So it's not common that medicines make the tics go away to zero. It's the expectation that the medicine will reduce the tics and improve the quality of life. So maybe less severe or less frequent. And when we treat tics, our goal is improving quality of life. And the most important and the most difficult is to give therapeutic trials an adequate dose and an adequate duration. And that means don't give up too quickly. So it's super, super common that when you have tics, you have good days and bad days. So tics wax and wane. It means there are days that they're really flared up and days they're really calm. And sometimes it's because of what's going on or definite triggers. Maybe there's a test, maybe there's an exciting thing. And sometimes it's completely random. So you can't have one bad day and think this medicine is a mess, I need to go off of it immediately, because it might have just been the natural fluctuations. You have to give the medicine time to take effect, and you have to allow for it to be adjusted up to the appropriate dose. So it might be the case that the first dose started didn't do any good, but that might not be enough of a dose. It might need some time to get adjusted to that dose and have it increase gradually. So you have to be expecting that and be cautious about giving up too quickly. So we can ask ourselves, is it true or false? Medications that we use for Tourette, even if they're not FDA approved, have tons and tons of really super good data and extensive research and large numbers of people who took them that definitely prove if they work or not. And the answer is actually false. The truth is that lots of different studies have been done, and they use different outcome measures. They use different scales. One might use one tic rating scale, one might use another. They might compare different doses of the medications to other medicines or to placebo. And sometimes we have a medicine that one trial said it worked and one trial said it didn't work. So sometimes the data we have can be a little bit confusing. It also depends on how many number of patients were included and whether people were analyzed who went off the medicine, because we don't want to just leave out the people who quit because it didn't work, or it'll make it look like the medicine's better than it is. So we have to think of these in the healthcare community. We have to pay attention to all these tricky aspects of interpreting the research. But this is the list of medicines that are currently used most typically to manage tics in Tourette syndrome. They're called alpha-2 agonists, dopamine receptor blockers, which are also known as neuroleptics or sometimes called antipsychotics because of being used in other health conditions, dopamine depleters, topiramate, benzodiazepines, botulinum toxin, and medicines that work on the neurotransmitter GABA in addition to benzodiazepines. So we'll go through these a little bit and talk about some of the pros and cons. The first class of medicine are called the alpha-2 receptor agonists. So these are medicines, usually in Tourette, we know that there's an overactive dopamine system. And we know this because of it being discovered that giving dopamine receptor blocking medicine, so reducing the dopamine neurotransmission, causes improvement in tics. So these medicines work a different way. And they tend to have a milder potency, so they're not the strongest medicine we have, but they can be helpful in mild tics and in tics that also have individuals who also have ADHD, because they can have a mild impact on attention deficit in addition to tics. So sometimes we can get a 2-for-1. We often start with these medicines because the risk of side effects is limited. So there's the most relevant side effects are tiredness and dizziness. They can lower blood pressure in some individuals. Theoretically, you could have a risk of passing out if your blood pressure got too low, but for the most part, we watch for dizziness and tiredness. So we don't have the possible risks of long-term effects that we do with some of the other medicines we'll talk about. Clonidine and guanfacine are the 2 generic names, and they come in the brand names that are listed. Guanfacine comes in the longer-acting forms 10x and Intunif. These medicines are used in the different doses that are listed here, and we always start really low and go up slowly. It's important that if you go up on the dose, when you stop these medicines, they're not stopped suddenly, because there can be a rebound of tics or anxiety or even blood pressure if they're from a high dose stopped suddenly. So I'm going to go on from that. The American Academy of Neurology looked at all the studies of these medicines, and they gave it a level B evidence. So level A would be the very best, meaning there are really good solid studies, lots of people, and good proof they work. B is the next, and C is less evidence. So this is kind of middle range. The next class of medicines, and the most commonly used and probably some of the more effective medicines, are called neuroleptics. We also call these antipsychotics, the older way they've been called. So the medicines on the left are what we call first generation, or the older medicines in this neuroleptic category. The medicines on the right are second generation neuroleptics. These medicines are not all FDA approved. So the only FDA approved medicines for Tourette are haloperidol and pimozide for adults, haloperidol, pimozide, and aripiprazole, also known as Abilify, in children. Everything else we're going to talk about today is what we call off-label, meaning it's been studied, it's been tried, it may work, but it hasn't been studied and pursued enough to get actually a stamp of an FDA label. And these are the names of these medicines. They've been given a level C guidance by the AAN, meaning there was the different medicines in these categories have some evidence, but they may be poor quality studies or not enough, and weighing the risks and benefits, that's the level of support. On this slide, which I understand you'll get a PDF version, there are dose ranges, and you can see there are a wide range of doses. The ones more commonly used are the ones on the left column and probably the top 2 on the right column. The bottom 4 on the right column are used infrequently with less good data. We don't use the bottom one at all, in fact, because it can cause some very serious blood count side effects, and there's limited rationale to use it in Tourette. But what should we know about this class of medicines? If I told you it was stronger than the first class I mentioned, you might say, well, wouldn't you just go to that class? Why would you mess around? Well, this is the reason. There are a lot of potential side effects of neuroleptics. The most common are the first 2, tiredness or somnolence and weight gain. So these tend to increase appetite and can cause very significant weight gain, and we have to monitor that closely. They can also cause what we call metabolic syndrome, which means an increase in the blood sugar or cholesterol, which can have other health implications. They can cause temperature dysregulation, maybe feeling hot, for instance, hormonal side effects. So they can increase a hormone that's balanced with dopamine called prolactin. And if your prolactin gets too high, you can have accumulation of breast tissue in boys. That's called gynecomastia. You can have galactorrhea, which is leaking of milk from the breast in a young woman who's not lactating, meaning she's not trying to have, she doesn't have a baby, and amenorrhea or menstrual cycle changes. So these have to be monitored for. Low blood pressure can occur, changes in heart rhythm, and depression. So Obviously, none of these are things that we want, but oftentimes when we start with a very low dose and we go carefully, we can avoid many of these side effects. The other side effects of this class of medicine have to do with movement. They can cause what we call extrapyramidal reactions. It means changes in movement that aren't due to any sort of paralysis in movement. They can cause sudden, what we call dystonia, involuntary muscle contraction, like a tilted neck or eyes being stuck from movement. They can cause a restlessness called akathisia, means like you can't sit still. And sometimes it's tricky to separate that from anxiety or ADHD with hyperactivity. But if a medicine like this was recently started and there's someone who's just constantly moving and they can't sit still and they're pacing and restless, you may consider that it could potentially be a side effect of a medicine in this class. Tardive dyskinesia is an important side effect because it can be permanent. Tardive dyskinesia is an involuntary movement that's not a tic. Most commonly, it may affect the mouth and tongue area. Sometimes it can affect the trunk or other body areas. And this is a movement that would be recognized by the treating physician and can be permanent if it's not caught and addressed. The truth is, studies have shown that it's less likely for an individual with Tourette syndrome to get tardive dyskinesia than someone who's taking these medicines with a different health condition. The risks are greater in elderly individuals and in higher doses and in treatment over time, but we still take these very seriously. Stopping medicine all of the sudden can raise the risk of this kind of a problem, and also taking higher doses than needed. So we always use the lowest dose that works, and if we go for a long period of time where tics are doing very well, we may even try to reduce the dose and see if it's still needed. So basically, the American Academy of Neurology guidelines suggest that physicians should use these medicines when the possible benefit is more than the risk. So we talked about all those risks, but if somebody is really suffering with their tics and they're affecting their well-being, then the badness of the tics outweighs the chance of having a side effect. So that's what we talk about with risk and benefit, is how much are the tics taking away from your wellness versus how much is the caution of having a side effect. And so we're always weighing those against each other. It's suggested that when these medicines are being used, that patients and their family members are informed of the risks and they're monitored for these risks, that the lowest doses that are helpful are used, and that we should always watch for all of those side effects that I told you about. It's also recommended that when these medicines, when there's a desire to stop them, they should be tapered gradually and not stopped suddenly. And that's because of that condition that I just told you about. There's another class of medicines that also works to reduce overactive dopamine function, but in a slightly different way. Instead of, this is kind of like a nerve, oops, this is a nerve, uh-oh. I don't know if that's something I'm doing, Juhi, or just time's out, but it's okay. Thank you for fixing it. So this is what we call a nerve terminal, and on the front end of it is where this neurotransmitter or brain chemical gets released, and that would be called dopamine, and then it would hit the receptor on the other side and do its function. So all the medicines I just said work on the receptors. These medicines work on the front end. So they reduce the amount of dopamine that gets sent out. And these are called vesicular monoamine type 2 inhibitors, or VMAT inhibitors. The oldest one on the market is called tetrabenazine or xenazine. And there are two cousins that have been developed that you're going to hear about most likely from Dr. Lehman that have also been looked at in Tourette syndrome. In the US, this medicine is actually only approved for a condition called Huntington disease, which is different than Tourette and also causes involuntary movements. But there is some evidence that this medicine could be helpful. The scary parts of this medicine are that in addition to reducing the amount of dopamine that gets sent out, it also can reduce serotonin, which is the neurotransmitter important in depression and anxiety and OCD, and depleting that can cause depression as a side effect of this medicine, even suicidal thoughts. So that has to be really monitored, and if depression is present, it needs to be addressed before considering this medication. It also can cause side effects looking like Parkinson's, meaning tremors and stiffness and slowness, and it can cause a lot of tiredness because of other things that are depleted, such as norepinephrine. It does have less weight gain than the class of medicine we just talked about. So that can be one appeal of this medicine. Another medication that is used is topiramate. This is actually a medicine that is used for epilepsy or seizures, and it's used for migraine management. And it's been tried in Tourette syndrome and tics and has shown some ability to reduce tics. So there are at least 14 studies that have shown that in some studies it worked as well as the neuroleptics that we talked about. But a big meta-analysis, which is where all the research that's been done is looked at together, showed that the evidence might not be solid enough to fully support it as a tic medication. It's definitely used, and it has a level B recommendation by the AAN, which is actually even a higher level than it gave to the classes of medicine that are FDA approved for Tourette. So we do use it. Instead of it causing weight gain, this medicine tends to cause weight loss if it does have a weight effect. So it can suppress appetite. It has a slight increase in the risk of glaucoma or kidney stones. So individuals who have that history or predisposition should avoid that medication. It can cause tingling in the fingertips, and it can cause trouble thinking of the word you want to say. So maybe slow thinking and word finding difficulty. So that can be a side effect. If that's present and you lower the dose or go off of it, it goes away. Some other medicines have been tried that have probably a more limited role, but sometimes we use them. Benzodiazepines are medications that are also used for many other conditions like sleep disorders, anxiety, and other conditions. These medicines can sometimes help if there's a high amount of anxiety, but they do have the risk of being habit forming, and they do have the risk of dependence or tolerance rather, meaning people can kind of get used to them where they don't work as effectively. They can cause tiredness, balance trouble, and confusion. And so we're very careful to use those medications. Baclofen has been looked at for tics. It's more like a muscle relaxer. It also increases this inhibitory neurotransmitter GABA. And this medicine most commonly would be used if someone also had a lot of muscle spasms. It can cause dizziness, tiredness, and constipation. And we don't use it very often for tics. So botulinum toxin is something that we use in certain types of tics. You may know this as Botox, which is one of the 4 brands of botulinum toxin that's on the market. This is a therapeutic that's injected that tends to cause relaxation of muscles, but it may have other effects that are relevant in tics. And some studies have been done where patients reported less urge to have the particular tics that were addressed. The way this would work is if you had a certain tic like eye blinking, it would be injected in the eye muscles that close the eye. If you had a facial tic, we would inject the particular muscles that are involved in that tic. Neck tics are especially amenable, so we would inject the particular muscles that are creating that particular tic. And vocal tics, such as loud coprolalia, meaning socially unacceptable words or phrases, or loud screaming tics, could be treated by injecting the vocal cords. The side effect of that is soft speech, potentially swallow trouble risk. And in the other areas we inject, the risks are weakening the muscles and having side effects related to overly weakening those muscles. This received a level C recommendation from the AAN, but it's definitely used in practice. Sometimes insurance limitations decide how much we can apply this therapeutic, but it can definitely be helpful for focal tics. So looking at all of those together, the most important things to remember are that we always start low with a very low dose and we go slow. We raise it gradually over time until we have benefit. The choice of these medicines, after you see that there are several options, depend on how severe the tics are, how urgently we need to get relief, and what else is going on in the individual's health that might influence what side effects we need to avoid or what might be the best choice. For instance, if someone also had migraine headaches, one might consider topiramate since it may reduce migraine headaches too. We also look at comorbidities, and we need to address other things that are affecting the individual, like their anxiety or their ADHD. We always start with the most bothersome symptom. We treat only when it's necessary, and we want to give medicines enough time and enough adjustment to allow them to actually take effect. And again, we have realistic goals about reducing tics that they may not be able to totally remove all tics. So how does this pan out for people who actually live with Tourette? with all these choices and not really all the best evidence, how do we know where to start? You might see someone like me wearing a button that just says, trust me, I'm a neurologist, and you're just supposed to, let me decide. Well, there are several different algorithms that are published, and there's not one size that fits all for every individual. These practice guideline recommendations are available. They're online. Your doctor can review these. You can probably review them too. This is one algorithm that was published by my colleague, Dr. Michael Oken. He suggested that first line involve behavioral therapies and the alpha agonists. Second line may involve those antipsychotics or topiramate and botulinum toxin. And third line would be dopamine depleting drugs like tetrabenazine, or in some rare cases, deep brain stimulation. But someone else published a different algorithm and put all of those things in a different order. So there's not really only one order. It's just to show you that there are many choices, and we have to look at all the factors involved to decide the best one. So when I'm on medicine, do I have to take it forever and ever? The AAN gives a level A recommendation to the fact that physicians prescribing these medications need to periodically reevaluate whether there's need for ongoing medical treatment. So after a period of time doing very well, some people might say don't rock the boat and stay, and that's a reasonable thing in some people. But in others, we would say it may be appropriate to reduce the dose and see if the medicine is still needed. So thank you for your attention. I'm always available by email, and I'll turn it over to Dr. Lehman.
All right. So thank you for that lead in and kind of getting us on track with some of the existing treatments. I'm going to talk a little bit more about some of the investigational treatments and kind of provide a general overview of those. And then Juhi is going to kind of step in and clean up and talk about in more detail a couple of the specific investigational therapies. Just my disclosures real quickly. I have participated in trials with a number of different pharmaceutical companies, including Neurocrine, Teva, and Emalex, some of which do relate to some of the treatments that I'll talk about today, but haven't received direct financial compensation for those. I'm also, as was mentioned earlier, on the medical advisory board and give talks through the CDC partnership, through the Tourette Association, and have done a little bit of consultant work for both Teva and for their medical advisory board and Ascension. And of course, because I'm talking about investigational treatments, everything that I'm talking about is going to be off-label. So let's see here. There we go. So the goals of this portion of the talk are really to identify some of the agents that are looks like my webcam just disappeared on me there. To identify some of the agents that are currently under investigation or in the pipeline for the treatment of Tourette disorder, and then also to explain some of the mechanisms for some of those agents. So, my portion of the talk sort of begs the question of, well, we just heard about a number of different treatments from Irene, and so, why do we need more? And really the answer is that our current treatments, while they can certainly benefit a lot of people, definitely fall short either in efficacy or in terms of side effects. So I kind of like this little cartoon here. Obviously this woman's having some difficulties with whatever it is she's taking. And we kind of see the same thing with some of our treatments falling short of the mark from where we would like to see them. So obviously with, the behavioral therapy was, a very exciting development that we had something that was not pharmacologic to offer people. But one of the major barriers with that type of therapy has been the fact that there is just a shortage of trained therapists around the country. And so just access is a major issue, particularly in kind of rural or outlying areas. The Tourette Association is working hard to help mitigate that and help to educate providers around the country by holding workshops and different sessions around the country. But that still remains a major challenge with that particular treatment. We heard from Irene a second ago about some of the limitations and issues with the alpha-2 agonists, both the variable efficacy in terms of some studies showing benefit from the medications and others being negative studies or kind of failing to show benefit. And if you look at sort of the subgroup analyses there, it does seem that those medications work better in folks who have the combination of tics and comorbid ADHD. But even so, for some of those patients, as well as certainly other patients who don't have comorbid ADHD, may not have the type of tic control with those medications that we would like to see. And then, of course, the D2 antagonists, which are certainly our more potent anti-tic medications, but also come at the expense of more potential side effects. And we just heard Irene talk about those as well. So that's sort of why we need these. And then talking a little bit about the process of kind of how we get there. So the discovery process is a long one. This is sort of outlining some of the phases in clinical trials in general. And so, of course, things start before we even get to humans in terms of discovery science in the lab, and then with animal studies. And then moving into human trials, working from phase 0 all the way up through phase 3, and then even kind of post-marketing type studies as well. So in the earliest phases of the studies, the phase 1 trials, these are very small numbers of patients. They are just really looking at the investigational product to evaluate its safety and get a sense of the most appropriate dosing. Moving on to phase 2 trials, which is the bulk of what I'm going to be talking about today, that's when they are looking at more patients, a larger number of patients, and looking both to assess the drug's effectiveness as well as to further evaluate its safety in larger numbers of people. And then phase 3 trials are larger still. They are to kind of confirm the drug's effectiveness, assess for side effects, and also compare to other therapies that are already on the market. So in most of the tic-related studies that I'm going to talk about, most of them are using a common primary endpoint, which is usually the Yale Global Tic Severity Scale. The Yale Global Tic Severity Scale has sort of 2 components. There's a total tic score, which ranges from 0 to 50, and then also an impairment score that also ranges from 0 to 50, so a maximal score of 100. Many of the studies just use the total tic component of the score when they're as their primary endpoint. And so the score is made up of different component parts. So in the total tic severity scale, you're rating the tics by separating them by motor tics and vocal tics, and then rating them on scales of 0 to 5, with 0 being least severe and 5 most severe in each category, with the categories being number of tics, the frequency of the tics ranging from less than daily to every 5 to 10 minutes, the intensity or forcefulness of the tics, so do people notice the tics because of how forceful they are, the complexity of the tics ranging from everything being simple tics, little kind of noises or fragments of movements, to everything being complex tics, or certain tics being complex tics with bizarre or kind of obscene gestures or kind of more complicated purposeful seeming movements. And then the interference, are the tics interrupting, kind of making people pause as they're doing things during their day, or disrupting where they're really stopping them from doing things. So this is most commonly the scale that we're looking at to determine whether these different treatments are working. So what are some of the products that have been looked at so far? So I have some of them listed here. On the left side of the screen are some that have been in trials in recent years and have been either found to be ineffective or where the studies were terminated because of equivocal or lack of benefit. And so N-acetylcysteine was looked at in one smaller study. That is N-acetylcysteine has been around for quite a long time. It's got a good safety profile, which is part of the reason it was of interest, and it's been looked at in a number of studies, particularly for OCD. And so when they looked at it in this particular study, it was placebo-controlled, and they actually did not find a difference in tic frequency or intensity between the treated and untreated groups of patients. The VMAT2 inhibitors, Irene mentioned tetrabenazine, which has an orphan drug indication, but I'm going to talk about a couple of the others in more detail on a subsequent slide, and I'll also go into a little more detail on the serine hydrolase monoacylglycerol lipase inhibitors in just a second. The ones that are currently under study are listed on the right-hand side of the screen, and I'll go into a little more detail on several of those. I will not talk in depth today about ondansetron, which is known by the trade name Zofran in the US. This is a selective 5-HT3 medication and is being looked at currently in a smaller trial, 5-HT2, I apologize. It may modulate the circuits involving the insula, the anterior cingulate cortex, and sensory motor cortex. So this kind of loop or kind of network that's happening in the brain is sort of how it's thought to work. And so that one is under study currently. The other trials that are listed below that, the subsequent 3 trials, are all being conducted in China. And I will talk a little bit more about the top 2, the D1 dopamine receptor antagonist, and you'll be hearing quite a bit more about the cannabis-related compounds from Juhi. There are also several devices that are currently being investigated, some of which I'll talk about today. There's an oral orthotic that has garnered a lot of interest as a potential non-pharmacologic option. Deep brain stimulation, which again you'll hear about from Juhi, transcranial magnetic stimulation, and then most recently some interest in median nerve stimulation. So you already heard a little bit about the pharmacology of the VMAT2 inhibitors with this presynaptic recycling of the monoamine chemicals in the brain, so dopamine, norepinephrine. They get repackaged in the presynaptic nerve so that they can be released again. That VMAT2 transporter is important for getting the chemicals back into their little synaptic vesicles, these little pouches that hold on to them, and then release the contents of those pouches the next time there's a signal happening. And so the VMAT2 inhibitors prevent these chemicals from being repackaged so that when those little packets open, they are essentially empty or depleted of the monoamines. So looking at the trial outcomes of the recent trials of these medications, so there were 2 studies, there are actually a whole series of studies, but I'm highlighting 2 of them here, the T-Force Gold and T-Force Platinum studies sponsored by Neurocrine, looking at valbenazine, which goes by the trade name Ingrezza. These were phase 2 studies. The first T-Force Gold was a dose optimization study, and that one failed to meet its primary endpoint. The second study, the T-Force Platinum study, was a randomized withdrawal study, meaning that everyone started out on the medication and then some of the subjects were withdrawn from the medication to see about whether there would be sustained benefit. And that portion of the study was stopped early for futility. There were also 2 studies of the ARTIST 1 and 2, and again, this is actually part of a larger series of studies of deutetrabenazine, which is a deuterated form of tetrabenazine, meaning that there's an extra heavy hydrogen molecule stuck on there that affects the pharmacology of the product. And again, these were phase 2 and 3 studies. The first was a flexible dose study, and that one failed to meet its primary endpoint as well. And the second, a fixed dose study, also failed to meet its primary endpoint. So at this point, it's unclear whether the sponsors will move forward looking at these agents or continuing to look at these agents in Tourette syndrome. But thus far, the results have not been as promising as we were hoping. One of the other issues with these medications, of course, is even when they are clinically available. So, you know, that's the thing. These medicines are out there. They're on the market for other things. Valbenazine is FDA approved for tardive dyskinesia. Deutetrabenazine and tetrabenazine are FDA approved for Huntington's disease, as Dr. Malaty mentioned. And so these are out there on the market, which gives physicians the option potentially of using them off-label for a non-FDA approved indication. However, one of the challenges with that is, in addition to the sort of less than stellar results of some of the recent clinical studies, even if you want to do that, the issue sometimes becomes insurance authorization and costs, because these are, as you can see here, extremely expensive medications. So I'm going to kind of stick in the ineffective or discontinued category for 1 second here and talk a little bit about serine hydrolases, just because it's sort of an interesting mechanism and sort of different than our other treatments that are out there. So serine hydrolases work as modulators of what's called the endocannabinoid system. So basically, we have cannabinoid receptors throughout our body. We have two different flavors of those receptors, CB1 and CB2, with CB1 primarily being in the brain. And so these endocannabinoid system is important for modulating or kind of adjusting some of the other neurotransmitter systems in the brain, including systems like the dopamine system. And so there are two main endocannabinoids, AEA and 2-AG. And so the compound that was being looked at was actually affecting this MAGL, this monoacylglycerol lipase. And that's the primary enzyme that is involved in breaking down this 2-AG. And so this was a study that was conducted by Lundbeck. They actually bought the rights to this particular investigational product from a company called Abide Therapeutics. So that's so the compound itself underwent a name change when it changed hands. This was a phase 2A trial. It was multi-center. It was randomized, double-blind, and placebo-controlled. They had 48 adults in the study. And again, as with many of the studies, the outcome measure that they were using was that total tic score of the Yale Global Tic Severity Scale. Unfortunately, what they found that there was not a statistically significant difference in favoring the investigational product at days 28 or 56. The common adverse events that they saw were fatigue, some disturbances in attention, nasopharyngitis, and paresthesias in the treatment group. So again, unclear whether they're going to be pursuing that further. They don't have information available about any plans to do so on through the company's website. Moving on to the currently under study grouping, wanted to talk a little bit about the D1 antagonists. So all of the treatments that Irene talked about earlier that are currently approved or used off-label currently, those antipsychotic medications, are what we call D2 blockers or D2 antagonists. This refers to the fact that in the brain, there are two families of dopamine receptors. There's the D1-like family and the D2-like family. So all of our current medications are targeting that D2-like family. There's a novel medication called ecopipam that has been of great interest because it is considered a first-in-class medication, meaning that it's the only thing like it on that's available. There's nothing like it on the market currently. And this is because it is a D1 receptor antagonist. So that trial is being sponsored by Emalex and is currently underway. It's referred to as the Diamond trial, looking at children and teens who have Tourette disorder, and they're studying 150 subjects. Again, this is multi-center, placebo-controlled, and randomized trial. And this one just ended recruitment, so still in process. There is an open label extension where they'll be continuing to study folks longer term. And so that one hopefully will have, by the next time we give this talk, some details on the outcomes of that study. Wanted to mention also cycloserine. So this is cycloserine is actually affecting a different receptor in the brain called the NMDA receptor. The NMDA receptor actually has two components, two subunits, an NR1 subunit and an NR2 subunit. The NR1 subunit is where glycine normally binds. And so glycine is what's called a co-agonist, meaning it's necessary for the receptor to work optimally. The receptor still needs to have glutamate bound to it to work, but glycine helps it work fully. And D-cycloserine is a partial co-agonist, so it binds at that same site where glycine would bind and has a similar activating effect. And so the thought is that D-cycloserine may help to affect the activity of the NMDA receptor, and that in turn may affect the pathways that receptor is active in, which are a lot of the memory and learning pathways in the brain. So the thought here is that it may affect what we call neuroplasticity, which is basically how the brain responds and changes in response to learning and over time. So in this particular trial, a researcher named Joseph McGuire, who's out at UCLA, is looking at trying to augment or enhance CBIT, HRT, which is the core component of CBIT, by using D-cycloserine to see can he enhance basically the learning or response to the habit reversal therapy. So to back up for a second, the CBIT, the Comprehensive Behavioral Intervention in Tics, has multiple component parts to it. But the core part of that therapy is habit reversal therapy, HRT, which is an older form of therapy that's been used for a number of different things. And so the thought here is that they're going to be giving the participants either a single dose of D-cycloserine or placebo immediately before they do a session of HRT. And then they're rating their tics both pre-treatment and 1 week post-treatment, in hopes of seeing that they get an enhanced effect of the treatment itself in the group that's received the D-cycloserine. And the reason this is relevant is because, you know, as wonderful as CBIT is, it's still we're getting about a 50% response rate. So if we could enhance that, obviously that would be very appealing. I wanted to talk about a couple of the devices that are out there because these have garnered a lot of interest as well. So this is an image showing the oral orthotic. So there were two dentists, Drs. Sims and Stack, who noticed in their own dental populations that they were actually finding that if in their patients with tic disorders, if they propped their jaws at a certain individual specific distance, that the tics seemed to quiet. And this was something they noticed in several patients and ultimately published their observations. And of course, this was of great interest to the Tourette community in general, and certainly to providers who see patients with Tourette as well. And people tried to sort of hypothesize why this might be biologically plausible, why this might be working. So a number of theories were out there. The first theory that the doctors themselves proposed was that it's possible that the jaw is sort of out of alignment with the base of the skull, and that's creating some pressure or irritation that's at a level that's sort of a sub-threshold level that the patient themselves isn't necessarily aware of, but where it's creating some irritation of the trigeminal nerve that sort of senses things in that area, and that is then leading to this kind of feedback with the tics. And so by alleviating that pressure on the trigeminal area, they're then decreasing the tics. That was the theory that they proposed. A lot of folks have questioned the biologic plausibility of that particular idea. Another proposal has been that, in fact, that they're just opening up the mouth, opening up the airway, better airflow, and that in turn is decreasing what we call the sympathetic response, which is sort of the body's fight or flight system response, and that's why things are quieting down. And the third that has been put out there is that this might be what we call a sensory trick. So in certain other movement disorders, specifically dystonia, sometimes we see that patients can find a specific position or behavior that can help to decrease their twisting or turning movements. For example, if someone has a cervical dystonia or a twisting of their neck, sometimes they'll find that if they touch their face in a certain way, that sort of quiets that movement. That's not a feature that's typically seen in tic disorders, but that was one of the theories behind why this might be working. So there is a study being conducted to look at the oral orthotic, basically comparing patients who are set with an oral orthotic that was at the distance where their tics quieted versus folks who are given sort of a sham that is set at some other random height. And so it'll be interesting to see the results of that as well. There are certainly a lot of people who have gone outside of study settings and found dentists to try to create similar orthotics for them outside of the research setting, but we don't have a lot of data at this point. Everything has been anecdotal thus far. Finally, this is probably the newest or kind of hottest off the presses of the device ideas. So this is actually a study that was published in Current Biology just this past June, and this one was sort of interesting. So it was a really nice stepwise progression in terms of how they kind of went through demonstrating this particular device or this particular idea. So basically what they were looking at is they were saying, well, you know, oops, let me back up one here. It looks like I advanced. There we go. Okay. So, so what they were noticing is that we know that tics are due to this imbalance in the excitatory and inhibitory forces in the brain, particularly in this network between the cortex of the brain, the striatum, the thalamus, and back to the cortex again to this circuit, and that there's imbalances in that circuit that are believed to lead to tics. And we also know that certain specific populations of brain cells play a big role in tics as well. And so there are oscillations or kind of regular patterns that we see in brain waves and that are reflecting the electromagnetic activity in groups of neurons, groups of brain cells. And this, we can actually see this on EEG recordings of certain oscillations that are happening in the brain. And those oscillations are actually coordinated by certain types of neurons called GABA interneurons. So we can modulate those interneurons in the brain using different techniques, specifically transcranial magnetic stimulation. The issue there is that can really only be done in a clinic setting, and the effects tend to be pretty short-lived. So, so this particular group was interested in saying, can we find a less invasive way of modulating those oscillations in the brain and the brain waves that would allow us to do that outside of a clinic setting? And so they postulated that if they stimulated the median nerve, it would kind of feed back to the brain and they could regulate the brain waves in that way. And so they actually postulated that if they stimulated the median nerve with a 12 hertz frequency at a specific kind of rhythmic frequency, they could, I'm not sure what's going on there, why it keeps changing itself, there we go. They could actually give a pulse train and that would lead to entrainment. And so the first portion of their study, they did exactly that. They did rhythmic 12 hertz, 10 pulse trains of 12 hertz frequency at the median nerve on the right wrist. And then they compared that with non-rhythmic pulse trains. So just kind of random, but for the same exact time period. And they found that the rhythmic stimulations led to entrainment of these oscillations in the brain, whereas the others did not. And then they went on to do a couple other parts of the study. They did looked specifically in patients with Tourette, and they gave 10 hertz rhythmic stimulations versus no stimulation, and showed that the rhythmic stimulations led to a decrease in tic frequency and intensity. And then they did a 12 hertz median nerve stimulation while they had people doing a continuous performance tasks. So basically what they were trying to show is that what they did show is that there were no increase in errors, no increase in reaction time. So basically what they were saying there is this isn't just because we're distracting them that their tics are happening less. They're not distracted. Their attention is the same when they're doing these continuous performance tasks. So so this is very interesting, and it'll be interesting to see how this translates into a kind of a clinically usable format. They've talked about creating something that was sort of a watch-like device that might provide this type of stimulation. So it'll be interesting to see where this research goes in future years. And there I will just kind of summarize things by saying that we obviously need effective, well-tolerated therapies in Tourette. Some of our therapies that have been investigated in recent years, valbenazine, deutetrabenazine, and the serine hydrolase that was under study by Lundbeck, have failed to meet their primary endpoints. And several are still under investigation, including ecopipam, which is a D1 receptor antagonist, and D-cycloserine, which is an NMDA receptor partial co-agonist. And then there are also several devices that are currently under investigation, including the oral orthotic, deep brain stimulation, transcranial magnetic stimulation, and median nerve stimulation. And with that, I will pass it off to Juhi to talk more about the cannabinoids and deep brain stimulation.
Great. Thank you so much, Irene, for your presentation and Becky for yours. I'm going to close out this session with the discussion, as mentioned, about cannabinoids and surgical treatments for TS with specific focus on deep brain stimulation. And so just in case you're wondering why this section will only cover 2 of the treatments, I think these are 2 potential treatments for tics and Tourette syndrome that do get a lot of attention, and people have a lot of interest in it. I think there are definitely some things to consider in terms of whether these are appropriate treatments for individual patients with tics and Tourette's, and so we thought we would take some special dedicated time to talk a little bit about each of these treatment options. So first, I think Becky kind of went over this a little bit, but as a review, what are cannabinoids? So cannabinoids are defined as any chemical substance that affects the cannabinoid receptors of the body and brain. And generally, they're called cannabinoids because they have similar effects to those that are produced by the cannabis plant, so smoking pot, basically, right? So we have these sort of receptors that are within our system, as Becky showed you. And if you think about the cannabinoids that are present in the plant itself, there's 2 types, and most of you are probably familiar with these. There's the THC and the CBD. So THC is the delta-9 tetrahydrocannabinol. This is the component of marijuana or cannabis that has a strong psychoactive effect. And CBD, of course, has a lot of interest, or people have a lot of interest in CBD because this can have a similar type of effect on symptoms, but without causing the high that people tend to feel with the THC. So there tends to be, if we kind of think about all of these different components, the things that are in the brain, the things that are available in the plant, you can kind of distinguish the different types of cannabinoids that are available out there for people to use. There are certainly recreational forms, and usually this is what people are talking about when they're either smoking marijuana or using marijuana in some way that allows them to get the high. There are medicinal versions of these medications in which cannabis itself is prescribed to relieve the symptoms of a medical condition. And so you might also hear this referred to as medical marijuana. People might, in certain jurisdictions, be able to get access to these medications in an official prescribed way. And then the third kind of use or availability of cannabinoids are the synthetic molecules that are designed to mimic the effects of THC, but of course to mimic the beneficial effects for health and illness as opposed to causing the psychoactive component or symptoms that are associated with use of this product. So the human endocannabinoid system, as was already pointed out, there are CB1 type receptors and CB2 type receptors. The ones that are probably most relevant to Tourette syndrome are the CB1 receptors because those are primarily found in the brain and the central nervous system, although there are other locations within the body where some of these exist. But what really happens within this endocannabinoid system? Well, it's a unique communication system in the brain and body that affects many important functions, as you see outlined here in this figure. They're made up of natural cannabinoid molecules and the pathways that these molecules interact with, and it regulates a number of different activities, including mood, memory, sleep, and appetite. And I think when you think about it that way, it might help us understand why there are some of these other associated symptoms that can come along with cannabinoid use. So what are those kind of effects? There are definitely some good effects that people enjoy having, and then there might be some not so good effects that are potentially problematic, especially when we're talking about trying to mimic these effects with medications or drugs that are potentially under investigation for disorders like Tourette syndrome. So the effects that people tend to like from the cannabinoids are things like the feeling of euphoria, feelings of well-being, spontaneous laughter and excitement, maybe the opportunity to have a quiet and reflective mood. These are things that people have reported as some of the benefits that they achieve from cannabinoids. On the other hand, some of the things that can come alongside that may not be so fun are things like increased appetite, dry mouth, anxiety, paranoia, and loss of memory. So there really are some potential concerns about the use of these medications or these types of medications or treatments on a regular basis for these reasons. There's also some concerning evidence about the potential risk of both structurally and functionally altering brain development. And so this is particularly of concern in Tourette syndrome in children and adolescents whose brains are still growing and still developing. And so we certainly don't want to recommend this treatment without having a better understanding of what those effects might be. And then also it's important to recognize that the effects, whether good or bad, might really depend on the content and the ratio of the cannabinoids, as well as the other compounds that are in the cannabis itself, maybe the route of administration, maybe drug-drug interactions, and maybe other patient-specific factors that we don't have a good handle on just yet that really determine the types of effects that individuals might get from use of these types of treatments. So still a lot to be understood about the cannabinoid system and the cannabinoid products and the effects on both adult and pediatric brains. So within Tourette syndrome, why is this important? Well, as was alluded to already, the endocannabinoid system modulates the release of most neurotransmitters in the brain. And that includes things like dopamine, glutamate, GABA, opioid peptides, and acetylcholine. So these are all different brain chemicals that are responsible for the cell-to-cell signaling that makes our brains work. And in particular with Tourette syndrome, we're obviously very focused on dopamine. And so there's a fair amount of evidence that modulating the endocannabinoid system can also modulate the dopamine system. And when that happens, there can be effects on tics. And this, of course, happens in the basal ganglia. So the basal ganglia are a collection of deep brain structures that are really intricately involved in the control of movements. And it is within these structures of the brain, as Becky was talking about, where the tics are thought to originate, and the chemicals in the medical marijuana are thought to affect the dopaminergic transmission and potentially control the tics. Now, there are probably effects of these types of compounds in other areas aside from the brain systems involved in dopamine or in movement production. So there's other neurotransmitter systems that are involved, as we talked about, with these different chemicals. And so the effects may also be seen in the comorbid conditions of Tourette syndrome, such as ADHD, OCD, and anxiety. And again, it's just a challenge of trying to understand which of those might get better or which of those might get worse to really understand the place of this type of treatment in the management of symptoms of Tourette syndrome. So there's a long history of this in Tourette syndrome. So for those of us who treat a lot of patients, I think we've all probably come across those that have tried smoking marijuana or using marijuana in some other way, shape, or form, and have all heard anecdotal case reports of people who are experiencing some degree of improvement in their tic symptoms when they use these types of treatments. And so it was really this history of reports that were coming directly from patients that really prompted the research interest in understanding how this cannabinoid system has impact on Tourette syndrome and how we can kind of use our medications or formulate medications to get those same effects without having to have patients engage in the smoking part of the marijuana. So several things have been reported by patients that have used this. So they might report a reduction in tics, they might report a reduction in the premonitory urges, they sometimes report that it improves sleep, it improves concentration, helps them relax, and maybe even reducing the depression, the ADHD, the OCD, and even those rage attacks. So we know that, of course, Tourette is such a complex condition when you tie together the tics as well as all the different comorbidities and and there's certainly a reason to think that there might be a potential for uses of these class of medications in managing symptoms of Tourette. So there have been a few randomized trials of cannabinoids in Tourette syndrome. The two that I've listed on this slide are actually the studies that were done of THC. So the first one was a small double-blind placebo-controlled crossover trial, low doses of THC in 12 adults with Tourette syndrome, and it showed a significant reduction in the tic symptoms that were reported by the patients, and that was a greater improvement than was seen with placebo. A second study was a shorter study, about 6 weeks, but also double-blind and placebo-controlled, this time a little bit larger, 24 adults, where THC compared to placebo was more effective in treating some of the outcomes assessed, whether it was tics or whether it was other behaviors. And this little picture on the bottom right here is just a representation of the chemical compound of THC. So some initial evidence here that that THC might be effective for treatment of tics. From that came this study that is conducted or was conducted in Germany, the cannabinoids in the treatment of tics. It's for short called the Cannatics study, conducted in Germany, but enrollment is now complete. I think we're just waiting to hear the results of this. But it was a multi-center randomized, double-blind, placebo-controlled, so all good indicators of good study design, phase 3 study in adult patients. So any individuals over 18 who had chronic tic disorders or Tourette syndromes were recruited into the study. And the objective was to try to demonstrate that treatment with a compound called nabiximols is superior to placebo in reducing tics and comorbidities in patients with Tourette and tic disorder. So nabiximols is a plant extract from the cannabis plant, and it contains a combination of THC and CBD in a 1-to-1 ratio. And the reason that this particular compound was the one that was used in this study is that that's the one that was widely available in Germany at the time that this study started. So despite the fact that there are these randomized trials that seem to show, at least in the case of the first two that I mentioned, some indicator of benefit, it's important to remember that there's really no additional case reports or scientific publications that indicate that THC or CBD are better, one or the other, or in what combination they should be used. And so for those who might be familiar with kind of the process of getting medical marijuana, sometimes you know that the formulation of a CBD or a THC ratio within those prescriptions can be altered, but there isn't really any clear evidence that tells us exactly what works best in patients with tics or Tourette. So there were additional studies that have been attempted. This was a study done in Canada, or attempted to be done in Canada, where they were, again, looking at adult patients and trying to understand the safety and efficacy of cannabis. So again, double-blind randomized crossover pilot trial. They were using vaporized medical cannabis products that had different THC and CBD contents as well as placebo, and they were going to try to address exactly how these compounds are sort of processed in the body by checking blood work and seeing if they could measure the effects and how those measurements correlated with changes in tic symptoms. And unfortunately, although it sounded like a very well-designed study and certainly would help us understand a lot about how these things work in patients with Tourette syndrome, it was terminated because of slow recruitment. So we already, I actually know this one we didn't talk about. This is a cannabis-based medication that's in development for Tourette syndrome. So again, a proprietary combination of dronabinol, which is a synthetic THC. This is developed by Therapeutics Biosciences. The formula numbers here are listed at the top. All of these things come with a combination of numbers and letters. But basically, this was looking at a combination of the dronabinol and PEA. PEA is another cannabinoid, which is naturally occurring in plant and animal sources. And this was kind of an interesting design choice because it's really trying to take advantage of what's called the entourage effect hypothesis. And so this entourage effect hypothesis is that there are multiple different compounds within the cannabis products or cannabinoid medications, and even within the endocannabinoid system that can works synergistically together. So if you just use one compound, you might get a certain effect. If you use another compound, you might get a certain effect. But if you use both together, then maybe together is better, and you can actually get more of an effect. So that was kind of the hypothesis here. So this was an early study, a phase 2 study, open label, for going on for 12 weeks, and the dose of the components is listed there. Small numbers again with 16 adults. They did show that there was an average tic reduction of 21%, and 6 out of those 16 individuals actually experienced a reduction of greater than 25%. So it was a notable improvement in the degree of tics. Unfortunately, there were a number of different side effects, including all of the different things that I showed you at the beginning, which might relate to fatigue or drowsiness, feeling high, dizziness or lightheadedness, difficulty concentrating, headache, imbalance, coordination difficulties, et cetera, et cetera. And so I think this, while encouraging, definitely highlights the fact that there are some challenges to using these types of compounds for the management of symptoms of Tourette syndrome. I'm going to skip over this one because I think Becky did a great job of highlighting it and explaining what was found in this study, but this was another cannabis-based medication that was investigated. And I wanted to bring you back again to the American Academy of Neurology guidelines that Irene mentioned. So these are guidelines that are intended for neurology practitioners, and really kind of a good place and resource to go for understanding kind of the latest summary of the available evidence on the use of various treatments for various disorders. And again, here in the Tourette syndrome guidelines that were recently published, they also specifically address cannabis and cannabinoids. And I just want to take you through some of the recommendations because I think they're worth talking about. I think one of the most important parts of this that they highlight is the part about where the regional legislation and resources allow. So this is not something that is available everywhere, or cannabinoid treatments are not available everywhere. It may very much depend on the region that you're living in and what is allowed in that particular state from the standpoint both of just medical marijuana, but also in terms of research on these products. So just be aware of that. And so where it is allowed, physicians must offer to direct patients to appropriate medical supervision. So it is definitely recommended by the American Academy of Neurology that if you are going to undertake this, or if a physician is going to recommend this to you, that they recommend that it be done under medical supervision. So not just going out and trying things on your own. It was also recommended that it could be considered in patients who were otherwise treatment resistant. So the usual medications maybe weren't working. They also mentioned that in adults who have already used cannabis efficiently as a self-medication, it might also be considered in those situations. And as is the case with the other medication recommendations that Irene talked about, it is suggested that you prescribe the lowest effective dose to decrease the risk of adverse effects, that we counsel patients about the potential for impairing driving ability, and that we periodically reevaluate the need for ongoing treatment with these types of compounds. So I think, a potentially supportive, but also cautionary recommendation from the American Academy of Neurology. All right, so then the second part of my talk is about deep brain stimulation. So first, let's just kind of review what is that. And I think a good way to sort of start that conversation is to understand that the brain is like a network of different circuits. And we have circuits that control movement, we have circuits that control memory, we have circuits that control language, et cetera, et cetera. There's lots of different circuits that control a lot of different brain functions. And when we think about movement disorders like Tourette syndrome, these are usually diseases that affect how well the movement circuits work in the brain. And what we can measure in the brains of patients with these types of disorders are abnormal firing patterns within those circuits that basically create a disturbance in the network. And what we do with deep brain stimulation is try to access those networks by inserting a wire that can deliver electricity to the nerve cells within those regions and restore them to a more normal level of functioning. A lot of these molecular details are still unclear. We don't have a 100% clear understanding of how this works in all the different conditions and under all the different circumstances that it might be used. But we do know that stimulation probably does not work similarly to the way that medications do, and so necessarily a lot of further investigation and study is required to understand how this particular treatment can help patients with disorders like Tourette syndrome. So as just kind of a brief historical overview, the first case of deep brain stimulation in Tourette was actually described in 1999. And this case was a 42-year-old gentleman who had a deep brain stimulator placed, and with the stimulator on had near resolution of his tics. And so whenever we have these kind of single case reports that sound very interesting, there's always an explosion of interest in trying to understand why this person or how this person had such great improvement. And so since that time, we've seen at least 7 or 8 different brain targets that have been explored for treatment of Tourette syndrome with deep brain stimulation. And really it comes down to 2 groups of structures within those brain circuits that we talked about that seem to be the most promising. So one is the centromedian parafascicular nucleus of the thalamus, also called CMPF for short. And then the other one is in the globus pallidus. And there are different regions within the globus pallidus that might be of interest, but I think the thalamus and the globus pallidus are really kind of the 2 main regions of the brain where people have been looking to see whether we can improve symptoms of Tourette syndrome. Now, almost all of these individual studies or small case series reported beneficial effects on tics, but these are uncontrolled cases. And so you've heard a lot about randomized controlled trials and really carefully studying investigational treatments. And so, you know, these reports of deep brain stimulation also need to be interpreted with a little bit of caution in that context. And there's been, of course, a wide variation in study methods and outcomes, so it's really hard to kind of come to specific conclusions about the efficacy of deep brain stimulation based on those results alone. So I told you that there were 2 main brain targets that are of interest, and I think in the end, we're really talking about 3 locations of stimulation where people may get benefit from DBS. So the first, as I mentioned, is the CMPF of the thalamus. What's interesting about this target, this is where that initial report from 1999 was targeting in that individual patient with Tourette syndrome. And so it's an interesting location because it kind of brings together the motor circuitry with that limbic or emotional circuitry that we know both of those circuits can be involved in Tourette syndrome. And so it was an attempt to really kind of target both of those pathways with the electrical stimulation and achieve improvement in symptoms. Within the globus pallidus, this is actually a brain region that is used in a lot of DBS surgery. So some of the more common reasons that we do deep brain stimulation are for things like Parkinson's disease and dystonia. And the region of the globus pallidus that is stimulated in those conditions has also been studied in Tourette syndrome. And there's a fair amount of evidence that patients can also get improvement with stimulation there. And then the last part is the anteromedial globus pallidus interna, which actually gets at more of just the limbic circuitry. So you can kind of see how these targets are related. As I mentioned, they're just part of the circuit, and you can get into that circuit at multiple different places, and probably more than one location will actually help to improve symptoms of tics. And this is why we're seeing a lot of data coming out from all these different regions of stimulation. So several years ago now, this was 2015, there was a recommendation about the use of deep brain stimulation in Tourette syndrome. And I'm just going to take a minute here to walk you through some of the inclusion criteria that were considered. First and foremost, a person needs to have a very clear diagnosis of Tourette syndrome as determined by an expert clinician. In this particular set of recommendations, age for surgery was not considered a strict criterion, but caution was recommended in anybody under the age of 18. When we were thinking about tic severity, the recommendation was that YGTSS should be at least a 35, which actually puts people in a moderate or severe range of tic severity. And there had to be a clear understanding that the tics were the primary cause of disability. So again, patients with Tourette can often have OCD or ADHD or other behavioral issues, but really here the primary source of disability should be from the tics themselves and not from those other conditions. And patients should have tried regular treatments. So whether that is medications, whether it's the CBIT, any of those other things that have been mentioned to you in the previous 2 presentations, if patients are really refractory to those treatments, then that's when surgery might be considered. And if there are comorbidities, those should be stable for a period of time, because we really don't want those to be impacting the either the symptoms that patients are experiencing or impacting the results from stimulation. There's also a recommendation here that the psychosocial environment for the patient should be stable, that patients should have been able previously to demonstrate adherence to recommended treatments, or are they following the treatment plan. And then also, as with most DBS surgeries, we recommend neuropsychological evaluation, and this type of assessment in patients who are being considered for DBS for Tourette syndrome should show that those individuals can tolerate the demands of surgery and the postoperative follow-up, and really be aware of the possibility that this might not work as well as hoped. So these are some of the main considerations. And so as you can see by that, it's not a hard and fast thing. There aren't, there's many different considerations, and a lot of careful thought has to be given into whether DBS is right for an individual patient. More recently, we came up with this sort of simplified categorization of the main considerations about DBS and Tourette syndrome. So we call this the 5 pillars in Tourette syndrome DBS, and you can see them kind of listed here. So the first is tic severity. We've talked about that. There should be at least moderate or severe tics that are going on. And really, we also recognize that when there's physically harmful tics, that may also be a reason to consider surgery. We also tie in here this sort of idea of the effect of tics on quality of life. And there is a way to measure this on that YGTSS scale that Becky told you about. And if the patient is consistently experiencing impairment on this quality of life measure or other quality of life measures over the past 12 months, then that's a patient who might be reasonable to consider for DBS. The treatment refractoriness we've talked about already, the fact that patients should have tried medications, the usual medications that are used for Tourette syndrome. But there's more to it than just, did you get a prescription and try it? I think there's a whole concept of, was it tried at an appropriate dose? Was it tried for an appropriate amount of time? Did the patient really kind of take the medication as they were supposed to? And then specifically with regards to the CBIT, were they either able to participate in it and didn't have benefit, or not able to participate because of the severity of their symptoms? And then the psychiatric comorbidities should, if they're present, should have it been either stable or decreased over the past 6 months before considering surgery. And then here again, the recommendation for age is adult patients are really the ones that we should be considering this in, although in select cases of individuals under the age of 18, this can be considered with the cooperation of an ethics board to help decide about the safety and the appropriateness of it. So here is a table that kind of summarizes the randomized trials of deep brain stimulation. So I told you at the beginning of this section that there were a number of case reports in small series, but there have actually also been some randomized trials of deep brain stimulation, about 5 of them, as I show here. You can see by the sample size that they're all very small studies. You can also see by the target here that different targets have been investigated. The study design was different in each of these. But they all had kind of a period where the patients weren't really aware of what kind of treatment they were getting, followed by an open label period where they had longer time to investigate the effects and also to optimize the stimulation parameters. And so if you looked only at the randomized period, you might not be very impressed with deep brain stimulation as a treatment for Tourette syndrome. Here we're talking about 6%, 37%, 15%, 10% improvement. It doesn't sound very consistent or very large, but what we do see here is when those studies went into the open label phase and the stimulation could be really titrated to the extent that was necessary for individual patients, you can see those degrees of improvement improving substantially, and probably more on the order of 40% in multiple of those studies. So the Tourette Association is supporting an international effort called the International Tourette DBS Database and Registry. And so registries are a great way to try to get more information on patients in a real world type of setting to understand exactly what's happening and what the trends are, and to see if there's patterns that we can identify that give us clues on how to really optimize the effect of things like deep brain stimulation. And so this effort probably has well over 300 individuals now. This might be an old slide, but there's over 30 centers participating all over the world with a number of patients and leads that have been identified and studied. So this was a report that came out a couple of years ago looking at the baseline characteristics of these individuals. And so this represents about 171 individuals at the time of enrollment. You can see here that the majority of patients in this registry are male. And so we know that Tourette is more common in males, so that might not be more terribly surprising, but this is probably a greater proportion of males getting DBS even than just what we understand about the proportions. The age at onset of Tourette was about 7 or 8 years old. The age at diagnosis was about 12 years old, and the age at surgery was about 29. So definitely a predominantly adult population according to the guidelines that we talked about as well. And most of these patients had comorbidities, the most common being OCD. The brain targets that were stimulated or looked at or implanted for these patients that were enrolled in the registry are, again, those main 3 that I told you about, and then there were a few cases that were stimulated in another area, which I can talk more about if people have interest in that. And then when we looked at the overall reduction in the tic severity score, it was about 40% at 6 months, 45% at 12 months. And so that really kind of parallels the open label sections of those clinical trials that I told you about as well. And although it looks here like the one of these GPI targets has less of an effect, I think there were much fewer patients that were in this particular group, and so it's hard to make absolute comparisons about one target or another, but I think overall patients were doing better with stimulation. And when we then looked at adverse events that were reported in patients who had undergone deep brain stimulation, there was a couple of things to note. First, one of the kind of really only unexpected side effects was the rate of infection that has been reported in some series of patients who have gotten deep brain stimulation for Tourette syndrome. And this is probably a little higher than we would expect to see in just a general movement disorders deep brain stimulation population. So it's something to just be mindful about. The most common set of side effects, however, were stimulation related, and this is not unusual at all. If you look at deep brain stimulation studies for any indication, most of the side effects are going to be related to the way the stimulation is being delivered. And, you know, kind of the good thing about that is that stimulation can be adjusted. So most of the time, these were things that could be minimized by just reprogramming the device. But what we notice about these stimulation-related side effects is that they really seem to be determined by the location in the brain that the stimulation is occurring. And again, this is what we understand about these particular brain regions. And so there really wasn't anything, aside from the infections, nothing else really unexpected about the safety profile of DBS and Tourette. So that's encouraging. Now, there have been some neuropsychological reports of outcomes, and so these are more extensive evaluations that then can start looking at the comorbidities and other behavioral or cognitive changes. And I've listed 4 of these reports here. None of them found any adverse outcomes in patients with Tourette syndrome. So I think DBS as a treatment is generally safe. The question really is about the candidacy for the surgery and also the efficacy and how to make sure that patients can get the best results possible. So in summary, what do you need to know about this topic, cannabinoids and deep brain stimulation? So for cannabinoids, we've mostly seen small studies, we've seen patient reports, we've seen anecdotal case reports that do suggest tics can be reduced with the use of cannabinoids, but there is potential for adverse effects from things like medical marijuana and related plant-derived extracts, especially in children and adolescents, and so we have to be very cautious about that. And certainly more research and larger studies are needed, and hopefully we will be seeing these coming out in the coming years. And then as far as DBS is concerned, again, open label studies have definitely shown substantial tic reductions in patients who have failed other treatments, but there still remain several unanswered questions about which target is best, which patients are best, and how really is the best way to study the response to DBS. And again, as with the cannabinoids, more research with well-designed studies are needed. So with that, I will close this part of the presentation, and thank you all for attending. I think, Angela, we are available to take any questions that might have come up.
Yes, thank you all so much for an excellent presentation. As she mentioned, we're now going to begin answering the questions that were submitted during the presentation. As a reminder, you can still submit your questions through the questions pane on the control panel. If we're unable to get to everyone's questions, here at the TAA, we do have a full-time information referral staff who can answer your questions as well by emailing support@tourette.org or by calling 1-888-4-TOURETTE. We will also be compiling the questions that were submitted and making the answers available to all participants. So don't worry if your question wasn't answered, we will get that out to you. Okay, so there's some questions. First one, can stimulant medication for ADHD cause tics? How do you know if it's that versus Tourette syndrome?
Well, I can start, and anyone else can also jump in. And that's a super tricky problem. And that's why I showed that natural history, that sometimes ADHD can be presenting first and medicines can be introduced. And how do you know if that person wasn't sort of destined to have tics anyway? Because that's kind of the natural history versus did the medicine bring it out? So I think part of it has to do with the time course. So if you had just started a new medicine and they came right away, well, then, you might suspect there could be a relation. Studies have shown that it's best to treat ADHD even with stimulants in individuals who also have tics, and that you can do that without worsening tics, and that as a whole, if you look at big groups of people, they do better when you treat it, and as individuals too. But there are some times that stimulants aggravate the tics, and so we kind of have to take each person and look at the timing of it and what good and what bad came out of each medicine and try to decide what we think is the best change to make.
Great, thank you.
I would just add too that, in most cases when I see people coming in with concerns about stimulant medications, what I've seen is either someone who had tics for quite a long time was on a stimulant, their tics changed in some way where a tic was more bothersome or happening more often, and then they stopped the stimulant medication. The tics may have predated them even being on a stimulant, and still they'll stop it in that situation where it's clearly not the cause and probably not even the explanation for the worsening, in that there was no recent medication change or anything like that. And a lot of times what I'll hear from parents is sort of some aggravation with, they're still having the tics, and we've stopped the medicine, they're still having the tics, and now they're failing in school. And so, I think being sort of cautious with making frequent medication changes in response to tic changes is warranted, because, we know that tics wax and wane, we know that they fluctuate, we know that they change over time. So I think in the absence of, really kind of impairing tics, that you can't kind of get past that initial hurdle of starting a new medication, I'm pretty hesitant to change stimulants because of changes in tics in my practice.
Great, thank you. All right, next question. Can antidepressants such as Prozac
Can they worsen tics is the question?
Yes.
I'll chime in here, and then if someone else wants to jump in as well. So typically, no, they don't typically worsen tics, and in fact, in some cases, may actually be helpful in improving tics, not directly, but indirectly. And I see that in two different ways in my practice. One is that we know that tics, while they are not caused by anxiety, they are not, people use the term nervous tics, and of course, tics are not caused by anxiety, but they are influenced by anxiety. And so if the sort of whole tone of the nervous system is kind of amped up on 11 all the time, that tends to make people's tics worse. The other situation that I see not infrequently is that in folks who have significant social anxiety in particular, they often report their tics as being very impairing and causing a lot of distress, making them feel very self-conscious, making them not want to go places. even in the absence of other people actually making comments about them, or even sometimes in the absence of really having objectively bad tics. So, if I'm sitting there in clinic and I barely notice their tics, or they're very mild or infrequent, and yet they're very distressed by them, in those cases, often treating that social anxiety first, what I see is that same patient may come back on treatment and say that their tics are so much better, and objectively they haven't changed at all. But their perception of not being under the microscope and examined by everyone is what's changed.
And the other thing is that a lot of times compulsions can overlap with tics, and tics can be compulsory. So in super technical terms, if we pretend they're totally different, we would say that an obsession is a thought that keeps coming in your mind even when you don't want it there. A compulsion is something you do because of those thoughts. It could be that you feel like you have to wash because you're afraid that you may be something may be contaminated. It could feel you have to do things in a certain way because something bad might happen if you don't. But the truth is that compulsion and tics overlap, mix up with each other a bit, and sometimes the tic has to be done till it feels just right, or a certain way, or in a compulsory way. And sometimes treating what may be a serotonin deficiency, taking a medicine called an antidepressant that helps obsessive compulsive aspects, sometimes help the tics in that way. I don't see antidepressants worsen tics at all.
Great, thank you. Okay, next question. Is the patient able to voluntarily move their muscles when Botox is used, or the muscles when Botox is used?
Great question. So if I'm telling you that this is like a weakening muscle, and you may have even heard of botulism, which is just like a bad disease that you can get from a bacterial poison and get really weak all over. But this is an engineered medicine where it's a partial relaxation. So if you think of it as the nerve is screaming at the muscle, like to squeeze, to squeeze, to squeeze, it just softens the signal. So it doesn't block it all the way. It doesn't make you, if it makes you paralyzed, then you got way too much of it. So we usually dose really small and work our way up, but it's a partial relaxation of the muscle. It's not a total paralysis. Otherwise, it would be no good at all.
So there's actually some evidence that the reason that tics can get better from injections, like for example with Botox or some of the other formulations, isn't so much because of the muscle relaxation itself. It might actually have to do with reducing the urges to make those tics. And so there's this complex chemistry that can happen. Although the main effect of something like Botox is within the muscle, there can also be effects on the pain perception or the discomfort sensations or perceptions. And so when people talk about urges, they're usually talking about some kind of discomfort in that region. And it may be that there is an effect like that also in managing the symptoms. And so we're not necessarily doing the treatment with the goal of paralyzing the muscle or making the tic physically impossible to happen. We just want, as Irene said, to just soften that signal and allow people to still be able to do what they want to do, but to have reduction in the problematic symptoms.
And there are certain tics that are sort of more amenable to treatment with Botox than others. So some of the situations where I think about it are certainly kind of dystonic tics, where it's kind of someone holding a prolonged posture, and particularly with really forceful neck tics, just to prevent injury to either the cervical spine or the spinal cord or things like that, where there's kind of a really forceful snapping motion. And again, there it's balancing the normal function of the neck, being just able to support your head, being able to turn and look and do all those things you need to be able to do, with lessening the force behind that movement to prevent self-injury. And that's really that's one of the situations. It can be used for vocal tics. I don't personally do injections for vocal tics, and would probably refer to some of my ENT colleagues for that. But it can be used for vocal tics in some cases as well.
Wonderful, thank you. Okay, next question. This one's a little wordy, so let me know if I need to repeat anything. We have tried pretty much all of the different medications that were mentioned over the years for my son, always with caution and slowly. He has been on something, mostly Abilify, since his tics went very high in first grade. One of my main questions for the doctors we have worked with is it common to go off of all medications for a certain amount of time in order to see what someone's baseline or new baseline is? Our son is now 13, and I feel like we don't have any idea what the top line issues he is facing are. Two other questions. Do you know of anyone we could ask about this? And is this something that is recommended or ever recommended by a Tourette specialist?
That's a,
Loaded question.
Yeah, it has lots of pieces.
I think that, to address the first part of it, I think, we've probably all come into contact with patients who just seem to have tick and tick and tick, and it kind of doesn't matter what type of medication we give them, or maybe people have been on certain medications for a long period of time, but they're still having very severe symptoms, and so much has happened since the time that they started that medicine that people don't always remember what may have happened when the medicine first started. So I do, on occasion, do what you suggested, which is trying to taper medications to see what happens. And I think that certainly should only be done under the supervision of a physician. It should be done very gradually and very slowly, because some of these medications can unfortunately produce other side effects or problems if you taper them too quickly. So it is a strategy that can be used, just to have some level of confidence about the continued use of those medications. And sometimes you find out, what, it was really doing more than I realized, and so stay on the medication, or you realize it really wasn't doing a whole lot, and then I take a medication. So I do think that's a strategy that can be helpful. So I would certainly talk to your physician about it. I think if you have not been seen at a center of excellence, then that might be something to consider. Usually centers of excellence have multiple disciplines that are available to assess patients. So both on the neurology side as well as on the psychiatry side and the psychology side as well. So you might be able to get a more comprehensive assessment of what's going on and what the needs are. So those are my suggestions. I don't know if the others have other thoughts.
Yeah, I agree. I agree wholeheartedly with everything that was said. And I think that, if your sense is we don't know what the issues are that he's facing right now, I think there are sort of two components to that. One is to find someone, whether it's at a center of excellence or someone in your own community, who can help to sort that out and to see what other comorbidities may be contributing to the overall presentation. And the second is to look at sort of functionally in kind of day-to-day life, what is and isn't going well. If he's, struggling in school, I think parsing out, is it because of bullying and teasing related to tics? Is it because of, he's having difficulty comprehending the material? Is it because of, attention and focusing issues? Is it because of low mood and it's hard to motivate to do this stuff? So all of these issues can interplay and have the same end outcome of poor grades. And so having someone who can help to sort through that and really pay attention to, is it impacting him? Just because you're continuing to have tics, we did mention before that not all tics need treatment. So sometimes, even though as a parent, we want everything to be perfect for our child, and we don't want them to have to deal with any tics, and don't want, to have any extra burden on them during what's often already a hard time in adolescence. Sometimes there's a little bit of a disconnect between that expectation and what the child's actually experiencing. So, I think, kind of re-updating that piece periodically too as he gets older, and can kind of weigh in on, because a lot of times people's resilience changes as they get older. They kind of develop other coping strategies and social skills and things like that allow them to be more resilient, even if the tics are still happening.
Wonderful, great, thank you. Okay, next question. I have many patients come to me who have been put on magnesium by other providers. Have you ever seen any evidence, or are there any investigations into magnesium? Similarly, there was a study that came out of China 2 years ago that looked at vitamin D in patients with tics, which suggested that vitamin D supplementation may help some patients' tics. Do you have any thoughts?
I think the question of supplements does come up quite frequently, as it does in most neuropsychiatric conditions, I think. And, I think there are potentially some reason to think that these might have some benefit, but I think that the magnitude of benefit that is seen with those types of supplements is very different from the magnitude of benefit that can be seen with some of the well-studied medications that were described. So I think that for the most part, these things are not going to hurt. The bigger question of how much are they going to help is, something that I think is probably not completely well understood, but it's also, I think, just on the basis of the experience that we've had in talking to patients such as yourself who have tried these things, probably not the same types of benefits that you could get from medications.
There was actually at least one study that looked at vitamin D in kids with tics, and some kids had low vitamin D, but there was no association with tic severity and vitamin D levels. So usually if it's deficient in something, there's value in supplementing it, but not really any, in my experience, great evidence of any particular supplement having benefit on tics.
Right, and I agree with what was said in that the two particular supplements that you're mentioning, if used in sort of typical doses, are probably relatively low harm and may even be beneficial, if not for tics, for something else like bone health or things like that. I do, have some concern sometimes when I see people come in who are on a laundry list of supplements without necessarily good evidence, because I do think that sometimes places people in sort of the expectation of being, that they are ill. And really the patients I see with tic disorders are by and large well. And I think, focusing on that and not sort of making it more of a burden than it needs to be is important as well.
Great, thank you. Okay, next question. And just FYI, everyone, the session is recorded and will be posted to our YouTube channel. And within a day or so, you should receive a follow-up email that has the link to the recording. So definitely will have access. Okay, next question. And can I just ask that the speakers just mute yourselves when you're not talking? There's some background noise, and I'm not sure where it's coming from. So how would you counsel a patient about using a cannabis product for TS?
Okay, so how would I counsel a patient? I think first and foremost, it depends on whether we're talking about an adult or a child. I have a lot of strong concerns about any children or adolescents either using or being exposed to this. And just remember, although there is evidence for and even approvals for using some of these compounds in patients, for example, with epilepsy, those are very particular treatments, very particular conditions, and what we've been talking about here are different from those. And so what you hear there may not apply to what is going on in the Tourette world. So I think that I generally don't support it in children or adolescents. I think in adult patients living in a jurisdiction where they can legally access these compounds, I don't have an objection for patients trying them. If there is, I'm in New York, and so there is medical marijuana. Unfortunately, Tourette is not one of the conditions that you can get a legalization card for, so it's just not even possible to get the medical marijuana here. But if it were, I would advise them to go and be treated by a licensed individual and to get their product from a licensed pharmacy and to kind of work directly with that individual on dosing and tolerability and things like that. So I think it's in an appropriate situation from a just sort of legal standpoint and also in the adult patient. I'm okay with patients being interested in trying it, but under appropriate supervised situations.
Yeah, and here in South Carolina, it's not, medical marijuana is not available. We do have CBD oil available, and I certainly have families of patients that I treat opt to use that on their own, and for a variety of indications, seizures, Tourette disorder, things like that. When people ask me my opinion on that, I typically say, because sometimes, of course, people initiate it without necessarily soliciting any medical advice. But if they're asking my opinion on it, I typically say, in someone who has failed standard therapies, it may and is having impairing tics, it may be reasonable to try CBD oil. But with all of these compounds, there's really no standard dosing. There's really no standardization between the different formulations. So it's hard for me to give any sort of real guidance on how to use them best. Unfortunately, you're often relying on the person in the storefront who's telling this is the dose to start at. I do advise them that they interact with some other medications depending on what else the child is on, and that we don't really have a lot of information about how they affect particularly the developing brain. So those are the things I sort of caution people with.
All right, thank you. Next question. With DBS, have you seen confusion or cognitive slowing accompanying adjustment in settings lasting 1 week or longer?
What was the second thing? Confusion or what?
Cognitive slowing.
Oh, cognitive slowing. Okay, so deep brain stimulation, as we talked about, is targeting the deep brain structures that are involved in movement. So a lot of the challenge with deep brain stimulation, the first challenge is getting the right patient. We talked a little bit about that. The second challenge is getting the electrode in the right spot. I think that's probably a little bit more challenging in Tourette than these other conditions, especially with some of the like the thalamic target or the anteromedial GPI target, because these are less commonly used for other things. And so targeting is always a question. Part of the reason that it is a question is because when we are programming deep brain stimulation devices, we have to be very precise in how we deliver that electricity. And so we have to be very careful about the dosing of that electricity. And this kind of process of programming is really intended to try to find the way to deliver the stimulation to get the clinical benefits, but without getting the side effects. So without really knowing too much more about what target was being stimulated or whether that electrode is in the best place possible, it's a little difficult to kind of answer that question. I would say, though, that if the timing correlated with the DBS adjustment, that's certainly something to consider. And I think if it is related to stimulation, turning it back to the previous settings that weren't causing that problem, or even turning the stimulator off, would probably give you an answer about whether it's a stimulation-related problem.
Great. And also for DBS, is it equally effective for motor and vocal tics?
Yeah, so I think in the cases where patients have had a response, there does not seem to be any indication that it is better for one type of tic or another. So again, we're targeting the circuitry. The circuitry is probably not very different for motor and vocal tics, and so we would expect both to get better, although individual variances are likely to occur.
Great, thank you. Okay, we have about 9 more minutes left for questions. There are a lot, so we won't get through them all, but as I said, we will compile them and send them off to the presenters and get them out to everybody. So the next question I have is, given the results of the recent RCTs with VMAT2 inhibitors, how efficacious would you expect tetrabenazine to be if it were to be studied in a high quality RCT?
That's a great question. And it, certainly, even though it has an orphan drug designation, I think that is a concern that I have. I anecdotally have not had tremendous success using tetrabenazine. However, I also, because of its cost, am typically using it in a very select and refractory population to begin with. So obviously not necessarily representative of how it would do for people on the whole. That being said, because of its cost and because of the lack of good evidence in related compounds, I've probably been more hesitant to use it in the past, 1 to 2 years with this knowledge of these other studies than I had been previously, or less enthusiastic about using it. Let me put it that way. So I don't know the answer. I think it would be, I agree, it would be interesting to really have that data, but it has certainly given me some pause, particularly given the cost of the medication.
Yeah,
I think another thing that I'd add, go ahead, Irene, go ahead.
Oh, okay. I think, and I'd be interested to hear what you have to say too. Becky, you said exactly kind of what I'm thinking. I actually think it should work because it's reducing dopamine. So if you can tolerate the serotonin impact and not have depression and not have side effects and not be too tired from it, it should work just as the others should have. But Our limitation is that in the system that we practice medicine in, insurers get to decide what people have access to based on cost and what they're willing to cover. And because it's expensive and super hard to get off label, because what insurance company wants to pay for expensive stuff? So if it's off label, they can say, we don't cover that, and we have to appeal and write letters. So the times that I choose to use it are people who have had really bad Tourette that nothing works for anyway. And so those are the only patients we're giving it to. And so it doesn't always work great because we're saving and only giving it to the really stubborn Tourette syndrome cases. Whereas I have a colleague, I just had this conversation yesterday, I promise, incidentally, and he works through the VA system where he is not limited by cost in prescribing that particular medication. And he thinks it works great because he gives it to a bunch of people, including people who don't have the most severe cases on the planet. And he has a really good response from it. So I do think it works. I think I have a hard time in the cases I use it in, also getting people to stick with it long enough to slowly get to the dose that works. People give up on it quickly because it does take at least 4 weeks to kind of get up to it. But my guess is that it would work in certain patients.
Yeah, I was just gonna, I think those are two great points that both of you made, and two that I was going to kind of make as well. I think that, my experience has been probably similar to your colleagues, Irene, where I've been able to use it more widely in patients at, different stages of their illness. And I definitely see that there are patients who respond well. And it might be one of these things where we have to understand a little bit more about the disease to understand which patients are going to have a good response versus those who are not. And I think we don't necessarily have a good handle on that yet. I think the other thing that I'll say is that the two compounds that were studied in clinical trials, those are kind of different versions of tetrabenazine. So they do have pharmacologic differences, and there's a lot that we don't understand yet, or at least that has not been made publicly known about why those trials didn't work. And so, for example, did it have something to do with the types of patients that were selected? Did it have something to do with the dosing? Did it have to do with, other things that patients were allowed to take during, the study? So I think, the more we can understand about those issues, I think will help us understand the role of tetrabenazine itself, which was kind of like the parent compound for these other two drugs. But I think there's a lot of interest in the community about why exactly those medications did not work in the clinical trial setting. And until we understand that, it's going to be really hard to say. But anecdotally, I've had a lot of good success with it. So in my heart of hearts, I would like to see it done. But time will tell us what we're able to do.
Great, thank you. Okay, next question. I understand that there are limited studies. However, have clinicians received strong anecdotal feedback that CBD alone has helped children or adolescents?
I think we've all had anecdotal reports. I think, and my goodness, if you go on the internet, you're going to find a lot of anecdotal reports. I think we have to interpret a lot of these with caution. And, patients are different, situations are different, formulations are different. I think there's not enough for me to really have a very clear sense of, again, as Becky was saying, how to advise people about how to use these products and how they're going to work or whether they're going to work. So I would interpret these reports that you would with grains of salt and understand that individual experiences and individual reporting.
I also would say that rely on cannabinoids. I think it's usually the THC that makes the impact. So I haven't seen a lot of just straight CBD being super helpful for people. And with that impact also come other issues. So it has to be weighed in that way.
Yeah, and I think also, even if you see an impact, sort of knowing whether that's truly a direct impact on the tics themselves, or whether that's a secondary impact from improvements in sleep, from decreased anxiety, other things. We certainly don't have answers to that. And to some degree, you might say, well, I don't really care what caused the improvement as long as there was improvement. And that may be true, but we don't really know sort of how, even in the cases where there seems to be benefit, is it all just perception and placebo, and that parents are and children are sort of expecting to see benefit from this because it's so highly regarded sort of right now in the media. or is it actually having an effect? And if it's actually having an effect, the question is on what? And so I think that's just too hard to interpret those anecdotal reports to know what to make of them.
All right, great, thank you. Next question. Are there gender differences in treatment efficacies? I ask because recent studies show that TS progresses differently for women than for men.
I'm not aware of any. Irene, go ahead. My short answer.
I was going to say we really can't answer that well because studies, there haven't, to my knowledge, been any studies that say only females allowed or only males involved. And in fact, I'm not familiar with any studies that really separated the difference in the impact. In clinical practice, I think what's important is that the genders have different prevalences of comorbidity, meaning which types of other symptoms are common with the tics as well. But in terms of the medicines, I think they work similarly in my experience in males and females, but that's not something that's been extensive studied.
I guess the only thing I can think of that was getting some weird feedback. If I try, okay, there we go. So the only, all right, so I'm gonna tap out of this one because apparently I'm getting some weird feedback.
So sorry about that, the sound, and now I'm getting some feedback as well. Well, we're just gonna end it there. It's 6 o'clock on the nose. There are still some questions. Will you guys just mute yourself? Maybe that'll help, Juhi and Irene. All right. Okay, that sounds a little bit better. Well, thank you all so much for such a great presentation and for answering all these questions. There are still a bunch of others. However, we'll get them out to you so that everyone can get their questions answered. If there's anything immediate you need to know, feel free to reach out to the Tourette Association over the next few days and we'd be happy to help you out. As I said, this is all the time we have for our presentation. Once the session is closed, you'll receive a survey from us, and we would greatly appreciate it if you would complete that and provide your feedback. You'll also receive a follow-up link within the next couple of hours to view the recording of the session, and it will be posted on the TA's YouTube channel for those who weren't able to participate today, and that goes for all the sessions over the course of the weekend. I just want to shout out the conference launch session that's happening at 8 o'clock tonight. Feel free to join us. And lastly, we do encourage you to reach out about this conference or for any other ideas and suggestions that you may have for programming. This presentation was presented free of charge thanks to our generous donors. And if you appreciated the session, we welcome you to support the organization by visiting Tourette.org to learn more. On behalf of the Tourette Association of America, thanks so much for joining us, and we hope to see you at more of the sessions over the course of the weekend. Thank you all so much for being here, and thank you so much for our wonderful presenters. Have a great evening, everyone.
Thank you.